Hi, I'm Naomi Murphy, and this is the Locked Up Living podcast, where we talk with a wide range of people about harsh aspects of institutional life.
We also explore some of the ways to overcome them and to grow and develop. I'm David Jones. So join us every Wednesday morning, 6 o'clock UK time, for a fresh podcast.
Rachel Gibbons is a consultant psychiatrist, psychoanalyst and group analyst, and she's been working on suicide, its impact on the bereaved and patient safety more broadly, since she was impacted following the death by suicide of 4 patients early on in her psychiatric career. We're really pleased to have you on, Rachel. It was really interesting to read your paper that you posted on LinkedIn, so it was good to have this conversation today.
Thank you. Nice to meet you.
Hello, Rachel. Thanks a lot for coming along to talk about this very interesting and very important area of work. So you recently published a paper, 8 Truths About Suicide. What led you to write this?
Well, this paper's been in the pipeline since 2009, published in 2023 when I had the opportunity to write about it. But around 2009, I started as a consultant in the NHS in the inpatient service. Very keen, very enthusiastic, thought I was going to bring good things. I'd had a training in psychotherapy as well as psychiatry. I thought, I'm going to do something good here. Landed on the ward, and in my second week, my first patient died by suicide. Third week, second patient died by suicide. Third month, we had an inpatient death on the ward. And I think that this is a whole layer of trauma we don't actually think about, but some of the audits we did showed it in around a third of cases in mental health deaths. A member of the team found somebody or someone died in front of members of the team, a whole different level of trauma, very traumatic, looked like the site of a murder, treated by the police as a murder. And then a few months later, another death by suicide. So in my first 18 months as a consultant, I had 4 patients die by suicide. So profoundly impacted, one after the other, with suicide. But not only that, after each one, I also experienced the organisational response through a serious incident inquiry to each death, and then a coroner's court appearance for each death. So that was my life for that 18 months. That was my life. That was my experience. I was absolutely run through in the experience of suicide, the impact of suicide, the response of society, and the response of the organisation. Well, whoever I was when I arrived on the ward, I was a very, very different person 18 months later. And I've spent my life since then trying to think, understand, engage, and process the experience I've had. I think now people talk about post-traumatic growth, this idea that actually, trauma can be destructive, or it can be that it's not that it's productive, but it can fuel creative change. I certainly am not the same person. Parts of me was absolutely destroyed by these experiences, but other parts of me have grown, and I seem to be spending my life, it's not just suicide, it's homicide as well, really, these days, but thinking about this, writing about it, talking to people about it, hearing narratives of people who've died and people who are bereaved, and trying to put these experiences into words. So it's 3 papers now that I've managed to get sort of produced in relatively short succession, which is the 8 Truths About Suicide, the Pathway to Suicide, which is trying to sum up the psychoanalytic understanding of the pathway to suicide, very much based on Rob Hale and John Campbell's book, fantastic book, Working in the Dark, understanding the pre-suicidal state of mind, and my interpretation of what their pathway is. And then Someone is to Blame, the impact of suicide on the mind of the bereaved. So it's the 3 papers really summing up, or trying to sum up, what I've learned over these years, sort of 15 years. And when I talk about working on it, I've been working obsessively on it. So about half of every week I spend thinking about suicide, talking about suicide, reading about it, researching it.
Thank you. You've told us there really what kind of impact these events had on you and your subsequent life. Was there anything else that you would add to that?
Well, I mean, I know in retrospect, what was very interesting, what I think is interesting, is that in 2008, 2009, when this happened to me, I know as a result of these experiences, I developed a very serious post-traumatic stress disorder. That seems quite clear in retrospect. At the time, absolutely nobody talked about the impact a death of patient by suicide has on clinicians. And actually, nobody really talked about suicide much at all then. I'm very glad, I think, in the pandemic, something of this started to shift. But still, in different environments I talk in, and in different countries, it's still not talked about at all, which is extraordinary because the research that we've done since seems to indicate that probably half, if not 3/4 of the workforce, mental health workforce, has been traumatized by a patient death by suicide or a patient perpetrated homicide. What does it mean then that we don't talk about it? And that means there's a lot of us wandering around with post-traumatic stress disorder.
Well, I'm probably one of them, because when I started work in psychiatry as a social worker, which was back in the 80s, we experienced 4 deaths by suicide, and they were all quite violent, shockingly so in some cases. I think we were working in a therapeutic community setting, so we did talk about it, but clearly they've left their mark, and I can remember the details of those people so clearly.
Yeah, well, it's very interesting. I think these deaths absolutely leave their mark. It's more than a mark. They're absolutely profoundly changing, because there's something about the contact with a death by suicide. There's something that suicide communicates in a very primitive way about there's something about the nature of humanity, something about the destructiveness at the heart or the core of humanity. So whatever I thought working in psychiatry was going to be like, and whatever I thought people were like, was absolutely changed by these experiences. You know, what leads someone to do something as destructive, as violently destructive as I experienced in these situations? And so that's a lot of thinking around that. And I have to say, you know, someone was saying, well, isn't it depressing to think and talk about suicide? And I was thinking, no, it isn't actually. It's deeply philosophical. There's something about thinking about suicide which really leads to very deep and philosophical discussions about the nature of what it means to be alive, really.
Thank you. Did you think your training prepared you for what you encountered in those first months?
That sort of makes me laugh a bit because there was absolutely no training. And I'll talk to clinicians now who work in mental health, and I'll say to them, well, how much of your day do you think you'll spend thinking about suicide? And actually, depending on the group, some of them will say actually all the time, because we also disguise the nature of suicide by calling it risk. And we talk and think about risk all day, every day. And what we're really meaning is suicide and homicide. And actually, we're in a job where we're thinking about suicide nearly 24 hours of the day. If you work in an inpatient unit, when I worked in an inpatient unit, you're identified with your team and your organization. So it's open 24 hours a day. So you live it, dream it, you know, all the time. So you're thinking about this all the time, which is quite sort of extraordinary, really, that we've chosen professions where we're doing that. There must be unconscious reasons for it. But what's more extraordinary is that we don't talk about it. And that in the training, in the psychiatric training, there was, until very recently, when we managed to squeak in a little bit about suicide and homicide, absolutely nothing about suicide or homicide, and absolutely nothing about the impact, which is just a wonderful testament to our capacity to deny, and stigma, really. I think it still has to be considered as being as sort of profoundly stigmatized.
So despite there being so little in the way of preparation and training, would you say it's quite common for staff in the NHS to experience this kind of event, killing by suicide?
So in mental health services and the research that we've done, and we've done research for psychiatrists and all mental health professionals, it's around 2/3 of the workforce that would be impacted in this way, to varying or lesser degrees. And just to say that actually we have done a lot of work in generating resources and guidance that people can find on the Royal College website, but also we've managed to develop national guidance for all mental health organisations. So it's Royal College guidance for all mental health organisations for the pastoral care of their staff. So people can access that and download it, and it's in the Government Suicide Prevention Strategy for England. So all mental health organisations should be putting in preparation structures, training, helping people with going to the coroner's court. So going to shadow someone to the coroner's court before they have that experience themselves, being involved in serious incident inquiries, all this sort of thing. But I'm not sure how much it's actually happening. And again, that's a sort of extraordinary thing, because in the aviation industry, for example, if you've got a very small chance that something bad is going to happen, tiny, even a millionth chance, you drill for it, you practice. In mental health services, it's in general, you're going to have 4 deaths in this way in your career, on average. Some people have more, some people will have less. You'll have 4 deaths of this nature, and we do not train for it at all. We don't put preparation in place, and therefore when it happens, everybody just runs around panicking, running in different directions and harming each other in different ways, breaking the news to each other in terrible ways, sending emails about it. And so there's something that we're all colluding in not facing the reality of the work we're doing and the impact the work can have on us.
Thank you. Naomi, I'm just wondering, because I'm thinking about the prison service and the kind of training that prison officers get. They probably get quite a lot of training for cutting people down and things like that. But then, of course, they don't have any opportunity to talk about it in the main. Would you say that's your experience?
Yeah, I don't imagine so. I mean, we had 4 suicides in one year in quite a short space of time, and obviously we were employed by the health service and we did run groups, so there was a lot of discussion in those groups, but there'd been no preparation before, even though it's a population that characterised by self-harm and self-destructive behaviour as well as homicidal behaviour. So, and I think we gave operational staff the opportunity to participate in those discussions with us, but I think probably what you'd get ordinarily is a debrief, post-incident debrief. No preparation. It's quite, just listening to you, Rachel, it's really quite striking and shocking in terms of the stats to think that there isn't training and preparation and discussion about it. And especially when you see what happens in the aftermath and the response of the system. And you kind of wonder about what's going on subconsciously in the psyche of an organisation when this risk is so prevalent.
Yeah. I suppose also, two things to think about that. I mean, of all the research that I have done and reading and focusing and thinking about it, I have seen absolutely no evidence that suicide is individually predictable. Absolutely none. It comes out of the blue. Everybody's surprised. It's the person people are least expecting to die. I've seen a huge amount of evidence that it's not. Individual suicide is not predictable. So it's a sort of very interesting, isn't it? The response afterwards, that somehow someone should have seen this and should have prevented it. And I think that's probably something to do with the nature of the traumatic nature of the death itself, that there's something about the nature of suicide that leaves everybody in a state of radical uncertainty. So if what I've seen is right, that actually suicide comes out of the blue, people aren't predicting the person who dies, it's very shocking. People are left not knowing why it happened, and there's no way they're going to find out why and how it happened. So they're left in a state of radical uncertainty. You're projected into by the person who dies. It's an acting out event you're projected into. And the result of this, and also you're confronting the destructiveness at the heart of humanity, which isn't just about suicide, it's also about homicide as well. There's something very powerfully destructive about it. It fragments your mind. It's very difficult to cope with. Nameless dread, confronts you with this. Nothing worse than that. So as human beings, what we do is we create delusions. We create narratives. So I don't have to be shocked and surprised and to think that I didn't predict this. Instead, I can write a narrative where I did know and I could predict it and I know what it's caused by. And we do this all the time, and these are delusional. These stop the fragmentation or the nameless dread, but they leave us in a terrible place with these encapsulated delusions of blame. So I don't have to not know. I now know that I did it or you did it, and you did it because you didn't do something perfectly or you did do something. And now I don't have to worry about how complex this is, how unpredictable and how traumatic. I saw it coming. And people will construct these narratives within 20 minutes of a death. So, and they pervade all our systems, and they pervade society, and you can see them in the media, and everybody sort of signs up to them, even though they are 100% hypothetical.
It's very similar to what happens in the aftermath of an assault, isn't it? An assault on a staff member, and the staff member will be blamed for doing whatever to have provoked this assault. I think, again, it makes everyone else feel safer if they think that staff member must have done something to elicit the assault, and therefore I can feel safer at work because I won't make that mistake that he or she did.
That is, but it's also a terrific example of stigma, isn't it?
Yeah, absolutely.
Something about the assault. I mean, that's terrible, isn't it? So the person who is subjected to the assault gets a further psychic assault by the system and the group around, which is the same that happens within suicide. That you see it, and I was talking to colleagues who are in Japan, and particularly talking about the environment in Japan. You see it actually all around, that the family of someone who dies, or whoever's working with a person who dies by suicide, actually can become very stigmatized and ostracized, as though they should have known, or even that they contributed to it. They're in some ways the perpetrator of this. And this is what happens in serious incident inquiries as well. There's a search for, because it's so very difficult to think about the agency of the person, we have to iconify them as a victim. We have to find the perpetrator elsewhere. And it's a terrible situation where you are both traumatized and then re-traumatized by psychic assaults from people around, the organization around.
Thank you, Rachel. Earlier on, you mentioned the coroner's court and having to go to the coroner's court, which is something I never had to do because that responsibility fell on the shoulders of nurses, consultant psychiatrists, and so on. But I wonder if you think the burden of the coroner's court hanging over psychiatrists, together with all the legal responsibilities around detaining people, whether that's an unhelpful burden.
I think there's two different things here. I think the detaining is one thing that I'll answer in a minute, and I'll think about the coroner's court first. I think there's a very big area to think about the coroner's court. This is something that Scotland don't do the coroner's court in the same way we do, and it's a different. And I think there is a less burdened by something. I think it is a challenging experience to go into because you're walking into the epicenter of grief. In some ways, I think the coroner's court has got two different tasks. One is just a factual task: who's died, how they've died, when they've died. And the other, I think, is the sort of unconscious task of the coroner's court, which is to contain an epicenter of grief, which can be very destructive. And this epicenter of grief is that someone needs to be held accountable. Someone needs to be blamed. As human beings, we're another really powerful aspect of the experiences I had was facing the need to scapegoat. That we as human beings have a terrible need to scapegoat other people. And it's a bloodlust. It's a sort of a bereavement bloodlust, very normal in bereavement, I've been terribly, terribly wounded and someone else needs to pay for this. And we call it someone needs to be held accountable. And what we really mean in that is someone needs to be held up and murdered in front of me. I want to see somebody else's blood and I do not care whose it is. It's a very primitive urge in grief. And so I've got a friend of mine who very tragically lost her daughter. And she said in the early period of grief, afterwards, I could have stood in front of her and she would have shot me and not thought twice about it. In some ways, a lot of the human tragedies, wars, everything is as a result of these early stages of bloodthirsty grief. And we have a terrible, terrible, capacity to not understand it and see it as part of the mourning process, but to collude with it and think it's a reasonable thing to do. So you see this happening within different organizations. I'm sure it's true in the prison service, which is, yes, someone does need to be held accountable. And we need to find a scapegoat for this as well. And we all support this unconsciously, and it's awful. And I think the coroner's court in some ways is aiming to contain that. But as a result, it can make it a very tempestuous and challenging place, because often the person or the people that can get identified to be the scapegoats can be those that work within mental health services. And I'm sure it's the same in prisons, isn't it? And that's part of the role. And that's okay if everybody respects that that's part of your role, but it's not okay if everybody colludes with actually that's okay and that actually you are to blame.
I was thinking about the dynamics and rivalries that crop up in multidisciplinary teams, which are often led by a psychiatrist. And, at times, I think other personnel might sometimes experience psychiatry as being a bit controlling. And I suppose my way of making sense of that was to think about, well, actually, there probably is this subconscious fear there, this unconscious fear there around where does a buck stop if something goes wrong, whether it either be a suicide or a homicide or some other serious incident. That I imagine that for the psychiatrist in the team, that they really feel the weight of that burden, even though probably everyone else in the team will feel just as bad and just as culpable. I think the legal responsibilities of a psychiatrist probably, well, I imagine that makes it feel more weighty for a psychiatrist.
Well, let me give you an example of this. I worked in a fantastic team, actually, a really good team. And we had a sort of play exercise where we were given to divide into our professional groups. And we had given some plasticine and we were told to create models of what we saw our professional role to be. And it was great. There was lots of psychologists in the team. There was lots of nurses. There was only really me as a psychiatrist. I was the only one. So, but you could see the psychologists looking over at me and thinking that somehow that we might be competing for the same space in a particular way. And they were, did this wonderful model that they revealed, and it was an amazing model of a brain with things going out and in, and it was beautiful, beautifully done. And I revealed mine, and it was a policeman's helmet and a gravestone. And you could see them looking at it thinking, oh gosh, we don't really want that job, do we? And I think that is true. There's something about the nature of both medicine. I think people, medicine, you carry a lot of the weight of death in training to do medicine. You see a lot of nameless dread in a way. You absolutely have to face that up in medicine all the time. And then actually, I think you do get to carry that sort of more, what is perhaps more the paternal role of having to stand in the coroner's court and carry the weight of having to talk about this and carry the responsibility. And I think probably doctors and psychiatrists probably feel very overly responsible, maybe due to certainly the personal background that drives you into medicine, but also to do with previous traumatic experiences, and having to carry the weight of that, the life-death weight of experiences. Yes, what I would imagine is you might have psychiatrists who are also suffering with post-traumatic stress, from these previous experiences. And maybe also, what was very shocking to me when I trained as a psychiatrist, and I think it might be changing slightly, is that you could work within mental health services in psychiatry and have absolutely no engagement with your own mental health at all. Now, that's not going to be a healthy place for anybody, really. So I think that is changing quite a lot. But really, to me, it seems like an absolute no-brainer that if you're working in these immensely challenging, really to the maximum, emotionally challenging environments, you really need some space for your own mental health and well-being and to work out what's going on in your own mind.
So also thinking, David, we've had so many conversations with whistleblowers, haven't we? And I suppose many of those people are people who have spoken up about something and they've expected to be backed by their colleagues because they've been speaking up about wrongdoing. And again, I think everybody in a team would probably say that they would all pull together and work cooperatively in the aftermath of a serious incident. But I imagine that anyone who can run for the hills and not have to take their share of responsibility, there'd be a tendency to do that. For people who are prepared to stick their head above the parapet tend to be in the minority, I think. So I think if people can evade responsibility, they would probably try to do so quite often.
I think there's so many different layers to that. I think there's one thing, if you take about a death by suicide, it's everybody has their own delusional beliefs, how they're responsible. They believe. So the last thing you want to do is come together and talk about it. So you often fragment and you fragment in that way. But I think the other aspect is this concept that everybody will stand together to support a truth that comes out. Well, that's clearly not the case. So I've just written a paper, hopefully it'll come out in the next few weeks, about the impossibility of working in the current NHS, where I think you're stuck between two different demands. One is an untruth, is a totally impossible demand, something you absolutely cannot do. So, for example, your job is to predict and prevent individual suicide. That is impossible because there's no evidence that you can do that. Yet you still sign up to that being your job. So there's a way we work in these environments where we are living with truths and untruths absolutely alongside each other. So if someone stands up for a truth, there'll be a lot of the organization standing up for the untruth, if you like. This idea that truth should out. I think if you speak truths within organizations are very complex things. If you speak truths within organizations, often you can absolutely be ostracized and be pushed out. So it can be quite a complex and dangerous thing, even though people might know that you are speaking truth. They're frightening things. Organizations are very frightening and dangerous places sometimes.
So Rachel, I'm just conscious as we're having this conversation about death by suicide, and I suppose there will be people listening who don't work for the NHS, for instance, or don't work for a public organisation. Could you describe for listeners what typically happens after a patient kills himself, and how much attention is given to the emotional impact of that, for instance?
I'm just thinking about where to start with that. I think this is not a rare event within mental health services. This is not a rare event. We treat it as though it's a rare event. It is not a rare event. Death by suicide is the greatest killer, if you like, for men under 50 and for everybody under 35. You know, in mental health services, you will see it quite a lot, yet there is very little preparation and there can be a lot of chaos around it. What there often is, I mean, it's getting a bit better, is there is a sort of debrief. There's usually people who gather together and you try and think through what's happened. And there might be some, if you're in a good, helpful, psychologically aware organization, there might be actually some proactive care for your mental health. But very often it does get ignored. And everybody carries on. And I've seen that very profoundly in different organizations. I've seen some very, very profoundly traumatic events, and everybody just carries on, goes into work the next day and carries on as though it's not happened. And you have the organizational response, which can be, we can't possibly. So I've seen a ward, for example, traumatized by several deaths in a short space of time. There's no space to process those. And everybody says, well, we can't pause or shut because of the ward pressure and the bed pressure. So, you know, it's a difficult environment. In general, you'll have the death. Then within 3 months, you'll have what's called a serious incident inquiry, where the organisation does a report, has an investigation into what happened. But these are very, very confused things. There is a sensible task, which is we need to harness the energy from this tragedy to examine a care pathway and to learn from it so we can change services going forwards. But that isn't often what happens. What happens is there is a confusion and people can think that actually the aim of this serious incident investigation is to find the cause of the death by suicide. And that isn't possible. You're not going to know. You're never going to know. It's going to be 100% hypothetical. So what people can do is they can go and examine the care pathway. They have a fantasy. It's based on their own fantasy, not on a reality of looking at different care pathways and saying what should be in different care pathways. But they have a fantasy of what the care pathway should look like. They superimpose it on the care pathway, and any imperfection anywhere that this doesn't fit their fantasy, they will say that someone didn't do this, they didn't fill in this form, they didn't write in the notes here, or they did make this phone call, and therefore these may be etiological factors to the death by suicide. Totally not based in health or reality. And then they can send those reports to the coroner's court, and the coroner relies on us to tell them whether these deaths are predictable and preventable. And if we say yes, and because someone didn't fill in the risk assessment form, that may well have contributed to that, that's what the coroner is going to take on board. So within about 3 months is a serious incident inquiry, and 3 months to sometimes several years can be the coroner's court appearance. So it can be a very, very long time that people wait. And coroner's court appearances can be very, very challenging, but also can, for quite a few people, bring closure. What picture they might have of what happened and their role in it. You go to the coroner's court and you might find that actually you're a very, very small player in a much bigger picture, which can be both a terrific relief and also a disappointment because you're not actually as important as you think you were.
Thank you. Why do you think people don't talk about it?
I think that's a question for us all to try and think about. I really don't know why we don't, other than stigma. other than that, actually, I think two aspects of the stigma. Stigma is still about suicide, but also stigma about clinician vulnerability.
Mm-hmm.
I think clinicians are very, 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 very bad at thinking about our own vulnerability. And actually, we are probably brought into this because we're highly vulnerable people. We work with vulnerability that we understand because we have our own vulnerability. But I think we're very, very bad at thinking about it and taking that on board.
We're not very good at talking about death generally in the West, are we? And I wonder, it'd be interesting to, I don't know whether you might have the answer to this, but I wonder what happens in countries where they have more rituals around death anyway, where they're more comfortable talking and thinking about death generally.
I think still with suicide, it can be really, really difficult because of the stigma. Often in countries where there might be more ritual around death, it doesn't mean that suicide isn't even very profoundly stigmatized. Well, I think that's probably right, but I do think there's something very much about suicide. And the suicide, what's interesting is if you look at the suicide rate globally, it has come down, and it seems to come down in countries where it gets decriminalized. So there's something about being able to talk, and it's only in the last 10 years, the last 5 years, really, we've started to talk about clinician vulnerability, that actually how important it is to destigmatize and to be able to talk about the impact on us and the impact on our patients for reducing the suicide rate.
Can I just clarify, did you say that the rate comes down when it's decriminalised? Because that's fascinating, because you would think that where it's criminalised, it would be a reduction on what the reality is anyway, with some masking of suicide as other forms of death because of the stigma. So that's really interesting.
No, I think people think in general now this is about decriminalisation. That this is a good argument for why the suicide rate has gone down in different countries.
Which I suppose makes me wonder how much of a fuck you suicide might be at times. That if it's not having that effect anymore, then...
Well, that's an interesting thought. It certainly is one of the suicidal fantasies that Rob Hale and Don Campbell talk about. They talk about suicidal fantasies that underlie the suicidal state of mind. So what they argue is that nobody really expects to die when they die by suicide. What they expect to do is get rid of this pain-ridden body and carry on living in a pain-free way, to get rid of the pain. And that they say there are different suicidal fantasies. One is revenge. Right. And you see this in some suicide notes now. You're never going to forget me now. Right.
Yeah.
This will serve you right.
Yeah.
Another one is assassination. So the dignitas type death of I'm going to assassinate the body because it's profoundly letting me down. There's the masochistic type of death. I deserve punishment. There's dicing with death, which I think we can get in mental health services. We can get that quite a bit, but also it's supported. This type of death is also supported and rather overvalued in society. So I don't know if you've seen the film The Alpinist, which is a young man who does all this free soloing up and down, these amazing mountains. And isn't he wonderful? Isn't he wonderful? Isn't this amazing? Well, no, he died at 25. So there's something about this type of suicidal fantasy that somehow fate will save me. And we have it within mental health services of people who repeatedly put themselves in death's way, and then mental health services save them, if you like. So, and then the fantasy that underpins all the other fantasies they talk about is that of merging, which is I'm going to go and join someone I've lost. I'm going to go and be with my mother. So I think suicide most certainly can be, and I think it probably can be these other things as well. But it's also very difficult to talk about that, isn't it? Because again, I think we need to iconify the person who dies, and there couldn't possibly be a violent underlying reason for them doing what they did.
But I think as well, you've covered sort of a breadth of possible motivations for it. So when we're trying to analyse what's happened and don't necessarily know what the motivation was for that individual and how much was despair and hopelessness and how much was revenge and rage, that it's quite difficult to analyse those events as an external observer, isn't it? Were you surprised by the reduction in the suicides post-decriminalisation, David?
I was a bit surprised, yes, because of course, I don't know whether you mentioned earlier on, Rachel, whether the rate was falling in this country, because of course it's been decriminalised in this country for
criminalised, but it hasn't really fallen. It hasn't changed much for the last 20 years. And is that possible for us to think about, really? People tend to think about it year on year. It's going up. And I was just in a meeting last week and someone said, oh, well, the suicide rate is going up now, isn't it? Well, not really. Now it goes up and down, bounces around a bit. And as soon as it's going up, people panic. And as soon as it's going down, people go, oh, yeah, it's going down. And then it goes up again, So it's pretty constant, really.
So, Rachel, I mean, you've touched on the fact that staff working in some branches of healthcare, like mental health, are much more likely to encounter a patient's death at their own hands. What's it like to work in a service where there's a high risk, where you're often face to face with a high level of despair and distress, or self-destructive impulses, or conversely, sort of, hate and rage and homicidal impulses?
Well, I think that's a very, very important question, isn't it? Something you could let me know about within the prison environment. I think it hugely varies. So you've got some teams. So, for example, crisis teams. Someone who works in a crisis team might experience a death by suicide quite a lot, but maybe we'll see it much more in the nature of the work they're doing, and also their depth of their connection or attachment to patients may be less. Whereas if you work in for example, a CAM service with young people, you might be know someone very closely and be very closely, intimately engaged with their family. So then you have a patient death and it's absolutely devastating. So what I'm finding out is that I don't know quite whether it matters which service or whether you're exposed to more or less. It's more the role that you have both in your mind in the death. So if you're the last person to see someone in A&E, you might not know them at all. But if you're the last person to see them, you might feel profoundly impacted by their death. But if you know someone really, really, really well, but actually the death isn't really aimed at you, or then you might feel fine. And it really, really depends. And I think it also depends on your vulnerability at the time that this happens. So sometimes I'll see people who are trying to make decisions about their life, or coming up to retirement or something, where a death really gets them in a very powerful way, in a way that it hasn't at other times. So I think there are these different factors that mean it's not straightforward at all. It's an unpredictable impact.
I think, though, we know that emotions are contagious, don't we? And I think, certainly the service that I worked in, patients were there for at least 5 years, had come with a background of committing a very serious violent offence, usually murder, rape and murder. And there's emotions that swilling around, like hatred, anger, sadness, shame, lots of really, really powerful feelings. I was conscious when we were talking earlier that each of us spoke about working in services where there'd been a number of suicides all close together, which seems like that's probably not really a coincidence. That when we know that emotions are contagious, we know that we can feel other people's energy at least 3 meters from our body. So actually, if we're interacting in these close-knit communities with people who are experiencing these strong, really deep destructive emotions, how do you look after yourself in that kind of, when you're in that role every day and amongst those emotions?
Yeah, no, absolutely. I think that there is certainly a good understanding that there are suicide clusters, that there's something about suicide that is infective, and people don't really understand what it is or how it is. I think a part of it may well be, my feeling is a part of it may well be the what I was talking about, which is the feeling of blame afterwards, this unbearable feeling of involvement, culpability, blame.
Mm-hmm.
And also the projective aspect of the acting out, that there's something projected into the environment in the death that then lands in other people. But I think, again, these are hypotheses. There's so much we do not understand, and we really, really don't understand. There's so much we don't understand. I remember hearing about someone going to the coroner's court because they had a patient died who had gone up some scaffolding. There was some temporary scaffolding, and this patient had gone up and died from this scaffolding, top of the scaffolding. And they went to the coroner's court to find that there were actually three cases being held together of 3 different people who'd done that within a week. And they didn't know each other or anything. So you're like, well, this is You know, who knows what's going on here?
Mm-hmm.
What's happened? Yeah.
So in terms of kind of like benefiting from your knowledge, Rachel, how could we get the balance right in the aftermath? You know, accountability often looks like blame, and is it fair to blame staff when they've not managed to keep a patient alive? And what could we do differently?
I think there's a huge bit there. This idea that, firstly, we can keep someone alive. I don't know where the evidence is for that. I don't know where we've got that from. This idea that we can keep people safe. What are we keeping them safe from? It's the contents of their own mind, and we can't keep people safe from the contents of their own mind. I've seen, you know, phenomenally creative deaths in inpatient environments. And I think there's something that's so destructive about this idea that we can keep people safe that seems to be throughout the system without any evidence. Now, I don't know that, you know, we have these beliefs that pervade our system and dictate to us how we treat patients and what we think is the right thing to do or not. One is admitting someone to hospital keeps them safe. Now, I don't think there's any evidence that admitting someone to hospital decreases their risk of suicide. I think there may be evidence that it actually increases your risk of suicide. I think there's a big debate to be had there, that what is it we're actually really doing? And I don't think there's any evidence that we can keep people safe. I don't know what that means. And if we have these beliefs, I think they're delusional beliefs that we can keep people safe. And if someone dies, then we must be responsible because we should have kept them safe. But I think what we're really, really struggling to face is actually the unknowability of our own minds, the unpredictability and unknowability and the destructiveness out of the blue of our own minds. And so we cover that up by saying, oh, we can keep people safe. We can control our minds. We can control other people's minds. And it's a total rod for our own back. We set ourselves up profoundly. And we also, you know, set people up to be scapegoats as well in this whole system. So we say to nurses, you should be doing 15-minute obs, do 15-minute observations, or observe someone all the time, and then we're going to keep them safe. I don't think there's any evidence that either one of those things does, but it also means that when someone does die on an inpatient ward, for example, whoever it is that's been doing that impossible task can be found to be, it was because they didn't fill in their check, or they didn't do their 15-minute check, or they fell asleep in the dark trying to watch a patient who's asleep. You know, it's you know, feeds into the whole need to scapegoat. We set people up to be our scapegoats.
Possibly increases the risk as well, doesn't it? I was just thinking about patients who feel a real profound sense of low self-esteem and lack of self-worth, and if the staff member hasn't done the checks at the right time, the patient of course feels really deeply uncared for by that, and then can end up feeling hopeless or angry. And so potentially it does amplify the risk that's there in the first place.
Absolutely. I mean, you know, the evidence for a lot of what we do, I'm not sure it's based on evidence. I think it's based on delusional beliefs about what it is we're trying to do. So, you know, I find myself, you know, very skeptical about it. And I think we should all be asking ourselves questions about this and not just going along with this idea. And I hear it endlessly. I admitted him so he would be safe, or I admitted her so she would be safe. Like, well, what gives you the impression that that is something that is going to work for that? You might admit someone because you want to bring them into a therapeutic environment where you can engage with someone in a particular way. There could be a reality-based reason for bringing someone into hospital, which can be put together. But to bring someone into hospital to keep them safe, I don't think is reality-based at all.
What would a good aftermath to suicide look like? You know, if there was a process that would be more conducive to recovery for anyone involved in the environment, what would that look like?
One is about, you have to deal with persecution and say that this is not okay. And I don't want to hear the word blame. Blame is a non-mentalizing word. It means that someone's capacity to reflect has collapsed. And what blame means is, I know who did it, how they did it. I don't have to be uncertain anymore. So absolutely, the word blame should not be used. I think what really, really helped me was the analytic attitude of Rob Hale, who came in to join us, which was benign, non-judgmental curiosity. which is an absolute understanding that no one is to blame. We don't know what happened here. We're going to have benign, non-judgmental curiosity together, and we're going to be joined together in thinking about that. And where it really works is where teams have done preparation beforehand, so that when they're put under pressure, because it really does put you under a lot of pressure, the anxiety, that when they're put under pressure, they've done some work beforehand that keeps them together and keeps them thinking together and not actively blaming each other. To have reflective spaces that they have well established before something like this happens really helps. Facilitated reflective spaces is what we're really banging a drum about. To have these embedded in different organizations where it gives you space to reflect. If you don't have spaces to reflect, it's not you're going to act out, you're going to cause more harm than good. To have embedded reflective spaces, which you can then go to, that are established, and you can then go to afterwards, really helps. So, and I think in the guidance we've written, we've got a whole list of things that we think helps, but those are the primary ones. The primary one is preparation individually and as a team. You prepare for it, and then when it happens, you've drilled for it, you know what to do. And nobody panics, and everybody holds together and say, remember, you're going to feel you're to blame, but you're not to blame. Nobody is to blame for anybody else's death by suicide. And that is a mantra to hold on to, I think is what's really important.
Well, it's really good to hear about these reflective spaces. I've been in many, many reflective spaces over the years, and sometimes it's jolly difficult to get people to feel safe enough, really, to engage with the process. Do you think there's something within the system and the structure of an organisation like the health service which makes this whole reflective process difficult?
Yeah, no, absolutely. I think there's different. I think what can get acted out within an organization is what can get acted out within our own minds. And if I'm talking about lots and lots of psychiatrists not having had any personal therapy, there's something that makes actually having reflective spaces quite a challenge, isn't it? That actually you have to reflect, you have to put yourself in a position to feel. As someone was talking about that when you're trying to work with people who are grieving, you're trying to help support them in facing really, really painful and difficult things. And actually, there's a big part of all of us that doesn't want to face these painful and difficult things, isn't there? So I think that both that's in the individual, but I think it gets profoundly enacted within organizations about it. I mean, again, absolute no-brainer to have reflective spaces, isn't it? But what happens is it's very difficult to establish them, and it's very, very difficult to get the management or the leadership to support them and to say, look, we really, really support you doing this. And when you do get that, when you get the leadership and supporting it really actively, I think it makes a lot of difference. But there's very, very difficult places to facilitate and to hold, aren't they? And people are dealing with incredibly difficult feelings and emotions, aren't they? Very, very painful. But, there isn't a reality-based or sane way out without some reflection, leaning into it. And it's definitely, from my perspective, for me, it's taken quite a lot. I've been doing this. I've been leaning into suicide and reflecting about suicide pretty much non-stop since these events happened to me. It's not easy. It's not easy, but the gains are big. The gains, if you can do it, as with grief, isn't it really? If you can do it, if you can lean into it. As Freud said, the ego grows through loss, but it's incredibly, incredibly painful work. It's life's great challenge, isn't it? It's very, very painful.
Yes, thank you. You've mentioned so much today, Rachel, and I think as a note to us, we probably ought to be doing another podcast on blame and scapegoating because they're so powerful and so prevalent. But how do you cope? I mean, you've had these very, very challenging and harsh experiences and you've immersed yourself in the field. How do you maintain your own well-being?
Well, I think I had a very traumatic experience of a patient self-harming when I was just emerging into psychiatry as a junior doctor. And I was absolutely, really traumatized by it. But what it did is it sent me into psychotherapy, training in psychotherapy. And so I trained in psychotherapy, had a lot of psychotherapy. had psychoanalysis actually and trained as an analyst and completed that just before I started as a psychiatrist. So thank heavens for that for me, because that holding on to that thinking and having, being able to connect with Rob Hale, who was an analyst and had been working on suicide, having access to that thinking in myself and in others was profoundly helped me survive, at least a part of me survive those experiences. So I was, very, very grateful for that. Personal therapy, various of various directions at various times. I think that it's a bit like being a musician. I think that if we're working in these environments with these very, very powerful emotions, there's something about constantly or intermittently or in different ways engaging in training our own personal instrument and being able to work through this so we can work through what we're carrying and functioning. I think another aspect is being able to make decisions that are I think, very, very difficult, but making decisions that I think are in my own best interest. At certain points, I think you can lose that. I was talking to a group of leaders in a different situation, and we talk about how easy it is to become identified with your organization. And you can lose yourself in that identification, and you can lose recognizing when it's right for you to leave. And then you're in a terrible problem. Then you're in a terrible pickle, I think. If you don't leave when it's right for you to leave your organization, I think really quite dangerous things can happen to you. It's a bit like not leaving a relationship at the right time. It can become abusive. And bad things can happen to you if you hold on because of your institutionalization. I think that is a problem. That can be a problem. So that for me, I think, is being able to be supported to make decisions that I think are probably for my own health and well-being, like leaving the NHS, I think in 2018 being one of them. Not that I regret the NHS at all, not that I regret it, not for a day, but I'm very pleased I left when I did.
Thank you very much. We've heard a few people say that, actually. Rachel, thanks very much.
So Rachel, I just wanted to quickly give you the opportunity to flag up any resources that are available to staff who've experienced such a death.
Well, just to say, I've got a website, which is drrachelgibbons.co.uk, which should have links to a lot of the resources and downloadable. College, we've got a page on the Royal College website, which is a bit hidden. I think it is available to everybody who goes onto it in the Wellbeing Hub. If you've had a patient death by suicide. But I think probably the website that I've set up, and I've set it up as a means for people to link to these different resources. So if you have a look at that, you'll find these different resources. We've got booklets, we've got videos, we've done all sorts of different podcast things to help and support the people. So very, very different to when it happened to me, there was nothing. And now there is actually quite a lot. And quite a lot of connecting to people. There's quite good ways of connecting to other people now who have been talking about this impact on them as well.
I know, I'm just really grateful that you're doing that work, actually, Rachel, because when you think about the statistics you've given us today, and people would have been coping previously in isolation with that. So it sounds like the work you've been doing will just be so invaluable to those people who are struggling.
I really, really, really hope so. I really, really, really hope so, because we have produced things that I certainly and other people I worked with wanted and would have felt we benefited from. So I really, really hope this, if that happens to anybody who's listening, that really, really are not on your own. You're so not on your own. Really do look at the resources, link up, and talk about it.
And thank you very much for coming on today. And we've got another conversation scheduled with you in the near future to talk about the assisted dying bill, which I also think will be very interesting to get your thoughts on. But yeah, I've really enjoyed today's conversation. Thank you.
Thanks a lot. Bye.
Bye.